Hi, everyone. Thank you for joining us. My name is David Rue. I'm the Global Chief Medical Officer for Microsoft, and we have an exciting panel discussion today on health equity, artificial intelligence, governance, and responsible AI. You're going to hear a lot of interesting things. And joining me to discuss these topics are some outstanding representatives from Duke Health. And well, maybe we'll start with you, Marcella. We'll have you introduce yourself, tell a little about your role, and then we'll move on to Michael.
Yeah, great. My name is Marcella Dalrymple, and I'm the Director of Strategic Development and Business Partnerships at Duke AI Health. And my role is really trying to get the organization ready to go along with this rapid pace of AI development and implementation, and also bring in new opportunities and figure out a best way to pursue those.
I'm Michael Pensina, Chief Data Scientist for Duke Health and Director of Duke AI Health. And in my role, I see it as kind of making sure that the AI revolution really delivers and delivers in an ethical and equitable way for all our patients, communities, and stakeholders.
So Duke and Microsoft have been on this journey, as well as many of you, to understand how AI can be applied safely and effectively within a healthcare setting. We have, in our journey, learned a lot, and I thought one of the things that could be worthwhile is if, Michael, you could just talk a little bit about sort of your background in terms of algorithms and understanding how AI could potentially be applied, and how this was being applied at Duke even before this whole AI revolution came about.
Right. So I started my scientific career with the Framingham Heart Study, developing risk prediction algorithms. Right. So I call it baby AI when you talk about the methodology and these functions. And going back to 2001, where the first algorithm was part of the statin lipid guideline. Right. And in 2013 update, I was involved in creation of these. But what I always wanted to know, not as much what is the math behind the algorithm, but really doesn't perform well and as expected, and what's the impact on the population, right? What will be the percentage of people that will be recommended for statins, how many events will be predicting, and so on. And I think that times have changed, where we had these functions supposedly applicable to the entire nation to much more local focus of health systems, right? And if you think about algorithms, you can think about broad algorithms like the one cardiovascular risk prediction for pretty much everybody, to much more local algorithms in the health system. What's the risk of rehospitalization? What's the risk of sepsis, and so on and so forth. And as David alluded to, even before the generative AI revolution that's unfolding in front of our eyes, we as Duke Health Systems have been confronted with a lot of algorithm developers knocking on our door and offering to sell or trying to entice us to use the algorithms in the context of our health system. And we were not prepared. Right? We didn't have the infrastructure or even the right people to answer the questions. Is it performing correctly? Is it adding value? Is it promoting health equity or exacerbating inequities? And fast forward to 2019 and 2020, right? 2019, my colleague Ziad Obermeyer published this really important paper showing huge racial bias in a popular algorithm, which that led to, I think, 17% of Black individuals qualifying for preventative care versus the real need was closer to 47%, right? So huge, enormous bias by simple mistake in how they set up the algorithm using a proxy of healthcare utilization rather than true health status. So that was one kind of red flag. The FDA issued their draft guidance of what they are trying to do with algorithms. And then the pandemic hit. And the pandemic brought forward a number of issues, right? All the troubles we had in healthcare got exacerbated, and the bias in healthcare came to the forefront, right? It was there, but during the pandemic, we saw how different populations are not treated equitably, right? And the disparities in care. And so what we did, we said, we need to do better at Duke. So we formed first algorithmic governance, went to the chancellor of the health system and said, if you don't want the mistakes like the one described in the paper I mentioned, we need to have a body that will govern the applications of AI and any other algorithms. And the health system leadership agreed. We formed our algorithmic governance committee, and that started in 2001. I joke we have the oldest AI governance in the country. It's 2 years old, right? And then working with colleagues from other institutions, Mayo Clinic, MITRE, and others, we formed the Coalition for Health AI, which this is a national effort dedicated to promoting guardrails for trustworthy AI, right? Taking what we have at Duke and scaling it nationally.
And you're bringing up a really good point about trust and trust in AI. Marcella, can you talk a little bit about, kind of your observation of, do patients and consumers and doctors, do they trust AI? Like, what is the current state, or at least what you're seeing? I would love to hear your thoughts on that.
Yeah, sure. So I think with a lot of patients, especially those in Durham, North Carolina, which Duke primarily serves, you see an inherent mistrust in the healthcare system. And that is based on historical things that have actually happened where they have been mistreated or exploited for the purposes of research. So when you introduce something else that they don't really understand wholly, then it only escalates the amount of mistrust that they have in healthcare and now a healthcare system, and they're joining forces. What are their true intentions, and how is it going to impact my care when I go to the doctor? Is it going to improve my care? How will it do that? Or is it just going to increase my bill on the back end because you're running all of these technologies and I never see the benefit of them? So in Durham, traditionally, I would say that there's a lot of trust in Duke to do the right thing because we do engage the community in a lot of aspects of our operations, and we get their feedback. We're constantly in communications with them. We have lots of groups that do community outreach. But now I think the challenge is communicating how we will be using AI in their care in a way that they can understand the benefits of it and not be reluctant to now come to the hospital or go to their doctor's visits if they know that they're using those technologies.
Yeah, absolutely. And we were starting to recognize that the need for us to be able to help address these issues is going to be something that would potentially involve some infrastructure, some support, some governance, some technologies. And it was a foundation for how Microsoft and Duke began to think about how we could create a center for AI excellence. And perhaps maybe, Michael, you can talk a little bit about what is that center, what are the mandates, what are you trying to accomplish with that?
Right. So to address the issue of trust that Marcella is talking about, right? Bring our patients, our communities, because again, we're kind of on an island here, right? We're at Health in Las Vegas, of all places. We're all excited about AI. We believe we need to revolutionize healthcare, and there is the nation, our patients and our communities, who are looking at it and saying, okay, it's the affluent doing things, right? And living on their island, and here is us, the community, and we need to change it, right? So the Center of Excellence we're forming with Microsoft, the goal is exactly that, is to make AI trustworthy. And trust starts really with documenting what you're doing, right? It's when I have conversations with patients, communities, providers, family, right, and I talk to them, what do you think about AI? What they generally tell me, it's bad, it's risky, I don't want to have anything to do with it. And I prop it a little bit and then kind of go deeper and say, well, so when you go to the doctor, how much time do they spend talking to you versus typing something on the computer? And they say, well, they type more than they talk to me. I said, well, what if there was a tool that could listen to a conversation and the doctor could just talk to you? It wouldn't have to do any of the computer writing, right? So you could have a visit with focus on you. Would you like that? And they say, yes, absolutely. That would be great, right? And so that's just one example where AI can serve the benefit and be helpful and be useful. But we need to start with recording, registering the AI tools that are running, that we can be clear and upfront to the patients and communities what's running, right? Because if you don't know, they think whatever is happening in the background, right? It's dehumanizing, it's automating, it's treating me as a set of numbers rather than a person. But those are real concerns, right? It's AI has the potential, and generative AI especially has the potential to do those evil things, right? So the concern is not unfounded. It could happen in the wrong hands. But documenting what we have, registering, that's one key step. Having a way also to monitor what happens, right? Once we've implemented the AI, we need to know that it's performing like it's supposed to over time, rather than deteriorating or being misused in some directions, and have a way of evaluating the algorithms in front of us that are putting in the health system, right? So it's really the registration as the foundation of transparency, it's the monitoring, and it's the evaluation of the tools that are put in, that are the pillars and principles of the center that we're discussing.
And one of the things that you had mentioned really is a prioritization of these use cases where removing the administrative burden that clinicians face so they can do their job being a high priority. Use cases and where are you starting to prioritize?
That's a great question. So, once the partnership announcement was public, my emails were blowing up. My Microsoft Teams was dinging every 5 minutes with the request to hear someone's pitch. And what we decided was to select use cases based on their data sources and the ones that we thought were going to be high reward or high impact and low risk. And so we have selected about 5 use cases in addition to scaling the process that we have to evaluate these frameworks that would involve billing and scheduling, those EHR extractions, automating registry updates and input of data. And we also have selected an imaging project where we would take all of the radiologic images and try to comprise a algorithm that could detect disease at an earlier state than the human eye could see on the scans. And uh, I think that we selected the best ones. We're very eager, and Duke has already hit the ground running with these ideas in the projects, and we just can't wait to see how they perform within the framework that Dr. Pensino was talking about.
Yeah, and I will add the selection of use cases is an extremely component of preparing for the AI revolution, right? It's when I talk about principles for trustworthy AI, number one, it has to serve the human person, right? It's non-negotiable. I take it a step further, like some people say, human in the loop. No, it's not human in the loop. It's really serving human on top, right? It's the technology serves human beings. Number two, coming from it, is selection of the use cases. It's having the AI strategy, knowing what you're going to work on, right? It's extremely important for every health organization. And there are a lot of organizations now jumping in saying, oh, we're going to take GPT and train it in this area, this area, and this area. And we don't know if it's going to be better or not, right? And so a lot of work going into it, but it's selecting the applications that we get to decide what it is and transparently register it and share it with our stakeholders, communities, and patients, right? Predicting what we can expect and monitoring for the unexpected adverse occurrences is critical, and then having the governance, right? So, but the use case selection is a critical component of it, and it's not easy, right? Because we're not ready. And then, as Marcella is saying, there are tons of people do mine. It's again, you have to have a system of prioritization because you're not going to do everything, and also you don't want to be doing something that Microsoft or another technology group is doing because you will be obsolete, right, by the time you're finished. So that's the tricky part, the strategy of AI.
And one of the things that we're particularly interested in understanding is that you have a lot of resources at Duke, and you're in a position to be able to do a lot of these things. How can this be applied so that even low resource institutions, organizations can take advantage of these governance processes and the things that you're describing? How do we democratize this for everybody?
Right, and I think that's where technology comes in, right? That's why we're excited to partner with Microsoft. So we have our algorithmic governance that I'm very proud of it. We call it the people process technology. We have wonderful people, we have solid processes, and we have fairly antiquated technology, right? And so I think we want to move it truly to the 21st century and automate everything that can be automated, still keeping the human on top, right? This is it's I want to be very clear. It would be very scary to have AI govern AI, right? I'm not proposing this. We're not ready for it. It's humans need to govern AI, but we can create the technological underpinnings and the infrastructure to make it applicable with the goal that every health system is able to have AI governance, the AI governance they need and they want to have. Because what I worry about is that AI governance becomes a luxury of the affluent health systems, right? And then if you're a patient who lives in an area where the health systems can afford and can think about governance, then they're protected. If you live in another area, you get the scraps and potential abuse and misuse. So that's a really, really important component. And that's the goal, right, of taking what we're doing at Duke on a national scale, working through the Coalition for Health AI.
And in one of the coalitions, on the topic of coalitions, we talk a lot about regulations and regulators and like where the industry is going relative to the need to regulate AI. Can you talk a bit more about like what you're hearing, seeing, and maybe the direction that Duke and others are taking?
Right. So I strongly believe that we need support from our government. I do not believe the government can fully regulate it, right? So in 2020, again, before the revolution, I published a paper and said no government agency will have the scope and size to regulate everything that's happening in the algorithm space, right? And now we have generative AI. I believe it even more strongly right now. So the government can create the right infrastructure, but it's truly the public-private partnerships, coalitions like the Coalition for Health AI, that need to develop standards. And we need standards that are national because we don't want to recreate the mistakes of the electronic health record, which is completely fractured, don't talk to each other, right? We don't want AI standards that are all over the place. So we need national standards, but the implementation of these standards needs to get more local because we, as a health system at Duke or any other health system, knows the health systems, the local setting much better than the best intentioned government in DC would know, right? So we want government to facilitate, but it's really the public-private partnerships and getting it to the local level to make sure we have the ethical and equitable implementation.
That's fantastic. So we're in our final few minutes. Just maybe we'll close with just a quick question for you both. What excites you about AI and like what with the next future? What do you think is ahead and what should we look forward to? So maybe I'll start with you, Marcella.
Gosh. I think there's a lot that excites me about AI, and I think it's the potential for it to solve a lot of problems very quickly. Um, especially when we're thinking about the operational issues that we've been having as a healthcare system, having experienced COVID, we are behind and we cannot keep up. We can't keep pace. And I think AI has the potential to get us back on a steady line where we are able to retain a workforce, we are able to train a workforce and grow the workforce, right? The clinician burnout is real, and those retention costs are exorbitant. So AI has the potential to really get healthcare, I think, in health systems back in a place where they can focus on innovation and not just keeping up with the day-to-day challenges that they've experienced.
Absolutely, Michael.
I will say I have a kind of long-term goal and short-term goal for AI. The long-term goal is the clinical applications, right? So a number of family members diagnosed with different forms of cancer recently, and I'm thinking if we can use the use case like Marcella is mentioning in imaging, right, to really identify it way early before it's formed, right, the stage zero. I think the medical technologies and ability to cure it with early detection is phenomenal. I think AI can be tremendously helpful, and this is just one area. But I will say the short-term goal is the operational use cases, right? The huge inefficiency, like ever since I remember, I hear about the health system and our kind of health enterprise nationally failing because of the inefficiencies, all with the billing and all those components. I think AI can do a lot of that, the documentation, capturing the conversations, creating registries. So I will say the short-term goal is the operational, the long-term is the clinical.
Well, this has been an outstanding discussion, and I'm not going to remember now human on top, not human in the middle. So, very good. Thank you all for your time. Thank you, Marcella. Thank you, Michael. And thank you all for joining us.
Yeah, thank you.